muchos de los que estamos aquí conocemos. Sin más preámbulos, Esteban, cuando quieras.
Bueno, muchas gracias Armando por la introducción. Como él dijo, en consideración a Tron, vamos a hacer las las presentaciones en inglés. My topic is the clinical evolution of PTDM. I will focus on PTDM after renal transplantation because we have very few information on other solid organ transplantations. But I will push a bit the line on pre-diabetes because in our group we've been always focused in the importance of PTDM and also pre-diabetes after transplantation. I will talk about definition, clinical evolution, the prevalence and incidence of PTDM and pre-diabetes, a kind of bimodal definition of the disease in early and late, risk factors and consequences. I recommend you the last consensus on PTDM that was performed in two beautiful cities, Imperial Vienna and Colonial Garachico in the north of Tenerife, two wonderful cities. And this more or less compounds the new advances in the disease. But what is the definition? The definition is simple. It's the standard definition for type 2 diabetes. Fasting plasma glucose above a level, use of antidiabetic medications, and an oral glucose tolerance test above a level. But the important thing, and this is why all studies showed different results, is that this definition shall be applied in stable clinical condition. You don't need to apply a diagnosis after surgery within an infectious disease, cancer, or when the patient is undergoing an acute complication. So, to discuss the prevalence, the incidence, and the change of in the incidence and prevalence, I'm happy to show you results of the multi-center Spanish study that was led by Dr. Armando Torres, and many of the collaborators are in the audience. I think it's a very nice study in which 8 Spanish centers participated from Barcelona, Granada, Santander, Bilbao, and Tenerife. Each center had to include 100 patients each. It has 3 years of follow-up, and 2 additional centers have 2 extra years. And we did OGTT at 3 months and then annually during the study. We evaluate the prevalence at different time points. At every time we did an OGTT, we analyzed prevalence. We analyzed incidence within different periods, 3 to 12 months, 12 to 24 months, etc. And we wanted to analyze the reversibility rate, if there was any, and the stability rate, if there was any too, and also risk factors. You can see the flow chart of the study. We included about more than 700 patients, and at the end of 3 years, we had almost 300, and 2 centers extended the follow-up with 100 patients. I mean that 116 patients reached 5 years of follow-up. I think this is the largest and the longest well-studied series around. The definitions of diabetes in the waiting list was excluded by the ADA criteria. We didn't do an OGTT in the waiting list because it is a most disease donor program, so it is complicated. And we applied the criteria I showed you in the post-transplant period. We analyzed reversibility as the withdrawal of insulin or oral medication on the normalization in an OGT, in the followed OGTT. The therapy is more or less the standard therapy. Prednisone, TAC, and MMF were used in the majority of the patients. And the first important figure of the study is that at every time point, 3, 12, 24, and so on months after transplantation, you can have about 20 or 25, up to 30% of the patients have PTDM. So 1 out of 4, 1 out of 3 patients that were not diabetics in the waiting list developed or had PTDM. But the important thing is that half of these patients were only diagnosed by means of an OGTT. So, you know, some studies are repeating always the same mode. OGTT is cumbersome, burdensome, expensive, whatever you want. But it's just 2 hours as it's not expensive. And in this population, you rule out 50% of the PTDM. So if you do not do an OGTT, you are not diagnosing half of the patient with PTDM. I think this is an important take-home message. The incidence at different periods is clear, you know that most of the patients appear or develop diabetes in the early period between 3 and 6 months. And then the incidence is low after 3-6 months. So, considering prevalence and incidence, 20 to 30% of the patients develop the disease. The cumulative incidence was 32%, and we found a bimodal incidence, early and late PTDM. This is another important figure where you can see that you have an early peak at 3 months, and we call it early PTDM, and then you have a late peak at 3 years after transplantation. If you see this figure, you see in the middle, always when you have 2 peaks, you have a valley in between. So we call it the valley of recovery, because this means that some patients with PTDM recover, so return to normality at 1 or 2 years after transplantation. And I think this is important because if you go to all studies, registry studies, once you got the diagnosis of PTDM, you were a diabetic all your life according to registry. And then we go to the fact that registries have no good quality data. And this is important to understand the disease. So between 3 and 24 months, 32% of the cases reverted. If you go to the old books, we learned that beta cells died. So beta cells showed apoptosis, no recovery, not at all. This means that beta cells do not necessarily die, at least in the PTDM scenario, and they are more resilient than previously thought. I think Armando will show you some data about these changes in beta cells, not dying, but changing into something. So another important point is that PTDM may be a reversible disease, and that PTDM can be defined in 2 different types, may be defined in 2 different types, early PTDM and late PTDM, which may not be comparable. The fact that late PTDM happens after 2 or 3 years, and the incidence was 7%, this is importantly the same incidence in the general population according to the classic study, a DPP study, Diabetes Prevention Program. They observed that the incidence of diabetes in the general population in patients at risk, and I will come to this later, is 7%. So after the nightmare of the early period after transplantation and after the honeymoon of recovery, we have the same incidence of type 2 diabetes in the general population. And if they recover, where do they go? 32% of the patients at 3 months had PTDM, and as you can see, 10% or 11% recovered to total normality. This is total normality because we did an OGTT in these patients. And 10% recover half. So by half, went to pre-diabetes. And 80% or 70-something stayed as PTDM. So let's go into the risk factors. It is just one slide because I think Armando will talk more about pathogenesis, but we always consider this disease as an interaction between pre-transplant risk factors. You can have standard risk factors like age, family history, gene, virus, etc. But we've done studies showing that obesity, metabolic syndrome, triglycerides in the waiting list are marking patients at risk for PTDM. And when you say this is a marker of disease, you also need to say it's a marker of what? perhaps this is a marker of dysfunctional beta cells that are not going or are going to cope with the atomic bomb these cells receive after transplantation, that is tacrolimus, surgical stress, high doses of steroids, whatever. So we always consider this as an interaction between pre and post. In the study, we showed that steroid dose, CNIs, and acute rejections were not risk factors to PTDM, possibly because now we're using low levels or low doses of these medications. But interestingly, early PTDM, risk factors for early PTDM were pre-transplant BMI, so obesity in the waiting list and age, and risk factor for late PTDM, and I think this is an important issue, was of course pre-transplant BMI, age, glycated hemoglobin at 3 months, but almost all the cases of late PTDM happen in patients with pre-diabetes at 3 months. So if you have pre-diabetes, if you are pre-diabetic at 3 months, you have a higher risk to develop late PTDM. It's obvious, but we need to see that in this different scenario that is renal transplantation. And what about reversibility? The DMO stands for occult diabetes, so the diabetes that are diagnosed by an OGTT. They reverted more likely to normal or to pre-diabetes. And the risk factor for being a persistently PTDM were higher BMI and higher glycated hemoglobin. So, as part of my conclusions, PTDM is more frequent than expected. OGTT is necessary to perform a correct diagnosis. Otherwise, 50% of the cases are missing, and 50% is quite something. We can discuss about the bimodal evolution, early and late PTDM, that may be not the same disease. Early PTDM can reverse up to 30% of the cases, and late PTDM occurs almost only in prediabetes, so we need to look for prediabetes in renal transplantation, and I will come later also to this important issue. So we discuss a bit about PTDM, and as I said in the beginning, I was not going to forget about prediabetes. If you see the same picture analyzing prediabetes, you will see that at different time points, 20 to 20-something% of the cases have prediabetes. So for one patient of PTDM, there is about another patient with prediabetes. So this is a not negligible thing. And importantly, most of the cases are impaired glucose tolerance that are only diagnosed by means of an OGTT, because impaired fasting glucose, you know, prediabetes is impaired fasting glucose alone, impaired glucose tolerance alone, or the combination of both. But most of the cases are impaired glucose tolerance, so you need an OGTT to diagnose these cases. And which is the evolution of prediabetes. 40% of the cases went to normality, so it's unstable condition. 30% of the cases remained, and 21% of the cases of prediabetic developed PTDM. And remember that prediabetes is the main source of late PTDM, which means that if we are able to intervene to do studies in prediabetic patients, we will be able for sure to reduce the incidence of late PTDM. And this is the analysis of insulin sensitivity or resistance in patients that develop late PTDM based on patients with prediabetes. You can see that if you move from persistent to reversible prediabetes, you increase your insulin sensitivity. And if you move from persistent to PTDM, you are increasing insulin resistance. So showing that the pathogenesis of type 2 diabetes, the general population is quite similar to the physiology of PTDM and prediabetes in the transplant setting. This is a study of Copenhagen showing that in blue is the pre-transplant, the blue circles show the pre-transplant insulin sensitivity of the patient, and you move to the white circle showing that after transplantation you increase insulin resistance. So you are promoting the evolution from insulin resistant prediabetes to PTDM. So another point is that prediabetes is as frequent as PTDM, and that all cases of late PTDM develop in patients with prediabetes. By the way, if you are normal by means of an OGTT at 3 months, it's very rare that you're going to develop anything, because 80% of the patients, 84% of the patients remain normal during 3 years. 14% of the patients develop new onset prediabetes, because it's expected, and few patients develop PTDM from normality. So it's important, because you are normal at 3 months, you are not going to develop major cardiovascular risk factors in the future. There are other studies with similar results. This is a study of the group of Trond Jensen showing that this disease is not simple, that evolved, it changed, it reversed. So we are not alone in these ideas. But what are the consequences of PTDM and prediabetes? I'm not going to say at all that PTDM is a cardiovascular risk factor, because it's obvious and you know that. I will focus more on the fact of prediabetes. You know that prediabetes in the general population is a risk factor for cardiovascular disease. There are classical studies showing that non-diabetic patients that go to the hospital because of myocardial infarction or stroke, many of them are prediabetics. Well, we evaluate the clinical impact of PTDM and prediabetes in our cohort. We did a survey that was finished some months ago. We were happy. We surveyed almost 98% of the cases, and we focus on cardiovascular events. This is the complete list of cardiovascular events, 116 cases. And considering the reversibility rate, we started analyzing cases at 12 months. So to focus on cases that are going to be stable for sure. And this is the incidence of event in patients that are normal at 12 months, that are pre-diabetic at 12 months, and that are PTDM at 12 months. You see the incidence of events in pre-diabetes doubles the incidence in normal people, and the incidence in PTDM is 3 times higher. And when you do a Kaplan-Meier analysis, you see in blue is normal people, in green is pre-diabetes, and in gray is PTDM. You see that the curves for PTDM and pre-diabetes in the studies associating these diseases with cardiovascular events are quite similar, because this is logical. You are treating this patient with diabetes from the very beginning. It's not like in the general population that we are diabetic 10 or 5 years after you get before you get the diagnosis. We are treating this patient for the very beginning. So the curves with PTDM and prediabetes are quite similar. And if you see this figure, prediabetes and PTDM are risk factors for cardiovascular events after transplantation, adjusted for many standard cardiovascular risk factors like proteinuria, smoking, weight, cholesterol, LDL, etc., and drugs. The important thing is that prediabetes is a risk factor in this population, as it is in the general population. So I think that the most important message of my talk, and I think one of the topics that we like to study more, is that prediabetes does exist in renal transplantation, is related to cardiovascular events independently of other risk factors, as it is in the general population. And of course, prediabetes is a neglected cardiovascular risk factor in renal transplantation, and it is a silent and untreated silent killer in this population. You know, I think that my personal opinion is that in transplantation, we've been monopolized by the industry, combining a lot of old and old medications focus on renal function. But these patients die of cancer, cardiovascular disease, and infectious diseases. And this is the fact, and possibly prediabetes is behind many of these cardiovascular fatal and non-fatal events. Thank you very much.